Assalamu alaikum. Hope you are all doing well. Today, our topic for discussion is birth after previous cesarean section. Reference is Green Top Guidelines number 24, published in October 2015. We will discuss details of this because some MCQs came from the details. So, antenatal care schedule. What is the recommended antenatal care for pregnant women with previous cesarean delivery? How will you schedule her antenatal care? So the first one is implementation of vaginal birth VBAC versus elective cesarean section checklist or clinical care pathways recommend to facilitate best practice is antenatal counseling, shared decision making and documentation. So this is very important that you have to discuss both the pros and cons of VBAC and cesarean section, and you will give a checklist. And the first one is important thing is that counseling is important in vaginal birth after cesarean section, share decision making and documentation. So in majority of the cases, counseling for mode of delivery could be conducted by a member of the maternity team soon after the woman mid-trimester ultrasound, assuming that there were no contraindication to plan VBAC. So you have to rule out all contraindication. An obstetrician should be involved in any way of the following situation. The woman had contraindication that precluded VBAC. She was uncertain of mode of delivery. She specifically requested for emergency for elective lower cesarean section. She required induction of labor more than 41 weeks or she developed specific pregnancy complication, for example preeclampsia, breech presentation, fetal growth restriction and macrosomia. So in antenatal counseling, the important thing is that you have to exclude that any contraindication in the patient for vaginal birth after cesarean section. So after initial counseling, some more complex cases may need senior support. In most cases, the decision regarding mode of delivery should be finalized by 36 weeks of gestation. So at 36 weeks, you decide, you have to explore the patient, you have to take the detailed history, any underlying condition like she's having any uh, underlying medical condition like she's having diabetes, hypertension, she's having a macrosomic baby, the current position is unchanged like breech presentation, whether the baby is having fetal growth restriction. So you have to individualize, because as in this case she's having two risk factors. With the first one is that she's having previous one, and the other thing is that, for example, she's having any chronic medical condition, maybe the patient will deteriorate. The other thing is that if the baby's fetal growth restriction, already she's previous one. So in fetal growth restriction, we need early delivery. If the CTG is good, we will do induction of labor. But with the previous one cesarean section, we will be very vigilant about the induction of labor. So in that case, you have to individualize, and obstetrician the senior obstetrician decision will be encountered in that what they will decide, what are their protocols. And because in some wards they will do induction of labor in previous one C-section, but in some because they have a bit not a good experience regarding the previous one or induction of labor, so they will straight away go forward for the cesarean section. So these are the important things that you have to exclude in patient, that whether she is a candidate for vaginal birth after cesarean section or not. And the counseling is very important. And sometimes the patient is having a trauma of previous delivery, that she's having a cesarean section, and they prefer that the labor was so prolonged, the second stage cesarean section. So the patient may need the patient say that I straightforward toward the cesarean section, but you have to counsel, you have to discuss both the pros and cons of the cesarean section, and what the patient is best for, what is the best for the patient, you have to discuss with the patient, and it is a shared decision. Now, which women are best suited to have a planned VBAC? Planned VBAC is appropriate for and may be offered to the majority of the women with a significant pregnancy of cephalic presentation at 37 weeks or beyond, who have a single previous lower cesarean delivery with or without history of previous vaginal birth. So if everything is normal, patient is having a smooth previous one with a in previous one cesarean section, you have to exclude that what are the indication of previous one cesarean section. If the previous one is due to scar rupture, so you will not give a trial of delivery. And the other things are that whether the previous one was preterm and on uterus vertical incision given. So these are the factors you have to rule out that whether this patient is a candidate for VBAC or not. So there is a the plan we make is safe and appropriate mode of delivery for a majority of the pregnant women with previous one lower cesarean section with no other cesarean sections. So what are the contraindication? Now we will discuss the what are the contraindication. Plan VBAC is contraindicated in women with previous uterine rupture. Number one is your this contraindication or classical cesarean scar. For example, she's a preterm and you will give a classical cesarean scar. The second one you will be that. MCQs came from this topic. This is very important. Yet you have to make a points of this contraindication. Or in whom other absolute contraindication to vaginal birth that apply irrespective of the presence or absence of scar. For example, major placenta previa. So your three contraindications are now. What are that? Previous uterine rupture, classical cesarean scar, and those having major placenta previa. In women with complicated uterine scar, caution should be exercised and decisions should be made on case to case and senior obstetrician and the detail of the previous surgery. So the first one is the previous uterine rupture. Based on limited observational data, women who have experienced a previous uterine rupture are reported to have higher risk. Normally, the risk of rupture is 0.5%, but with the after VBAC, the risk of rupture is 0.5%. We will discuss later on, but to those with the previous uterine rupture, risk is 5%. It is so much high of recurrent uterine rupture. So hence, previous uterine rupture is a contraindication to VBAC. This is one of your SPA. Now, type of uterine incision is very important. There is insufficient evidence to support the safety of VBAC in women with previous inverted J or T incision. Lower uterine, vertical uterine incision or significant inadvertent uterine extension at the time of primary cesarean. Hence, caution should be exercised in these women and decision should be made by senior obstetrician on case-to-case basis. Sometimes the previous cesarean section with depend upon the obstetrician choice. But the better option is that VBAC is contraindicated in women with previous classical cesarean section due to high risk of uterine rupture. So you have to avoid. The next thing is previous uterine surgery. Although previous uterine surgery is not with the scope of this guideline, there is uncertainty whether women have undergone laparoscope or abdominal myomectomy, particularly where the uterine cavity has been breached and increased risk of uterine rupture. Uterine rupture after hysteroscopic resection of uterine septum is considered a rare complication. Given this uncertainty, women have such uterine surgery should be considered to have delivery risk at least equivalent to those VBAC and managed similarly in labor. So, specifically those with usually in our setup when there's myomectomy and the cavity is breached, so our better option for the patient and safest option is that will not proceed toward the VBAC, but the better option in that cesarean section. So you have to keep in mind that it depends upon the obstetrician choice, but the better option is that you will proceed toward the cesarean section. Now, placenta previa. A major degree of placenta previa and some cases of minor or partial placenta previa is contraindication to vaginal delivery, including VBAC. In systemic report that 1, 2 or 3 or more previous cesarean section experiences 1.7 or 2.8 risk of placenta previa in subsequent pregnancy. So this one is your in recent GREED top guidelines. We will discuss in placenta previa. The percentages are different, and in this VBAC guidelines the percentages are different, but we will follow the one with the placenta previa guidelines, because in that a bit percentages are increases. So with previous one there is 1% chance next of previa, with previous to 1.7% chance that the patient is having previa, and that the rest is 2.5. So we will follow the guidelines of placenta previa guidelines. Now, placenta accreta occur in 11 to 14% of the women with placenta previa and prior cesarean delivery, and in 20 to 30% of the women with placenta previa and 2 prior cesarean delivery. So with previous one, with the one previa, there is chance that accreta occur in 11 to 14%. And those with the placenta previa with previous to cesarean delivery, the chance of cesarean delivery is 23 to 30% of the women with placenta previa. So there are your percentages that you have to memorize. This in women with placenta previa and 5 or more prior cesarean delivery, the incidence of placenta accreta is up to 67%. So these percentages we will discuss in the placenta previa and accreta guidelines, and we will follow that. Can women with 2 or more prior cesarean offer plan VBAC? Women who have 2 or more prior lower cesarean may be offered VBAC after counseling by a senior obstetrician. This includes the risk of uterine rupture and maternal morbidity and the individual likelihood of successful VBAC. Given a history of prior vaginal labor, should be conducted in certain with suitable expertise and recourse to immediate surgical delivery. So basically, and with the placenta previa with the prior to cesarean section, we will usually avoid vaginal bag after delivery, because with the chance of rupture is more in that case. So with the VBAC with 2 or more previous cesarean deliveries compared with single previous cesarean section, these findings occur with other observational studies. Overall, similar rate of VBAC success with previous 2 cesarean section, that is 62 to 75%, and single birth. So after cesarean delivery, the chance of successful VBAC is approximately 62 to 71, and they said that with the previous 2 cesarean section, the success rate is same like 62 to 75%, but it will be depend upon the obstetrician choice. It is notifiable that more than half of the women with previous 2 cesarean have previous vaginal birth and 40% have previous VBAC. Caution should be applied when extrapolating these data to women with no previous vaginal delivery. So better to avoid in these patients. So women seeking multiple, either 3 or more further pregnancy, should be counseled that opting for emergency cesarean section may expose themselves to greater surgical risk, particularly placenta previa, accreta, and hysterectomy associated with repeated emergency cesarean section delivery. So you have to tell the patient that with the cesarean section in future, if 3 or more cesarean section there is if she's opting for cesarean section, you have to tell that there is a chance of placenta previa, accreta, or hysterectomy in future pregnancies. So better if there is no contraindication, you will tell the patient that the better option for her is VBAC. What factors are associated with increased risk of uterine rupture in women undergoing VBAC? So what are the factors that in VBAC that increase risk of rupture? So what are that factors? Factors that potentially increase the risk of uterine rupture, including short interpregnancy interval less than 12 months since start delivery, post-date pregnancy, maternal age of 40 years or more, obesity, lower pre-labor Bishop score, macrosomia, decreased ultrasonographic, lower cesarean myometrial thickness. So these are the important points you have to, for SBA point of view, and in journal as a clinical point of view, that when you are doing your training, you have to when you are taking the history from the patient with previous 1 C-section, the important thing you have to ask the patient that what are the when was her previous cesarean section, what about her what is her dates, and what about the baby weight, and how is the ultrasound lower segment myometrial thickness. But these are very important, because if the short interpregnancy interval, there increased risk of rupture, so you will better option for the patient is proceed toward the cesarean section, not toward the VBAC. So because with the lower success rate with these factors, so that's why the what factors decrease the increased risk of uterine rupture. So these are the factors in patient with the short pregnancy interval, post-date, and age of 40, they are more prone toward the risk of uterine rupture. So a recent study that women undergoing VBAC with a short pregnancy interval, the study included that When it is less than 12 months is not a risk factor for major complications such as uterine rupture, maternal death, but it is for preterm delivery. Further data are needed before the safety of such approach can be confirmed. So they said that the a bit studies. A retrospective study done on some patient that what are the factors because they said that they increased risk of uterine rupture, but with the data they collected, so they said that a major complication uterine rupture, maternal death are is not a risk factor, but a preterm delivery is a risk factor in that case. There is uncertainty in how to incorporate this knowledge in antenatal counseling, and therefore, the presence of these risk factors does not a contraindication to VBAC. However, such factor may be considered during the decision-making process, particularly if considering induction or augmentation of VBAC labor. So they said that usually these are the factors that we have. They are increased chance of rupture in women undergoing VBAC. These are the certain factors you have to consider, but the vaginal delivery after cesarean section is not a contraindication for this. You have to give trial to these patients, but under close surveillance and the consultant decision. A recent meta-analysis suggested that measurement of lower uterine segment thickness antenatally in women with a previous cesarean section could be used to predict the occurrence of a uterine defect, scar dehiscence, or scar rupture in women undergoing VBAC. According to the study, a myrometrial thickness, the minimum thickness overlying the amniotic cavity at the level of uterine scar cutoff is 2.1 to 4 mm, providing a strong negative predictive value for the occurrence of uterine defect during VBAC, whereas the myometrial thickness cutoff between 0.6 to 2, providing a strong positive predictive value for occurrence of uterine defect. However, the study could not define an ideal lower thickness cutoff value, unstable in clinical practice. So the meta-analysis provides support for the use of antenatal lower uterine segment measurement in the prediction of uterine defect in the woman undergoing VBAC. However, clinical applicability need to be assessed in prospective observational studies using a standardized method of measurement. So they say that the myometrial thickness you have to be considered, but it is not a clinically there is a practice that we have to check the lower uterine myometrial thickness, but it has not a good predictive value, and they said that you have to consider that this will be individual approach of every obstetrician and depend upon her experience. So later on, the experience is very important in these cases, that how whether for example, if you do a research and you have to check the patient the thickness of the how the thickness affect the delivery VBAC, and how the patient proceed toward the normal delivery or increased risk of cesarean section, increase of uterine rupture. But this is the but you have to consider, you have to keep in mind that these are the factors you have to keep in mind and individualize and every obstetrician choice that how they will proceed toward the in clinical practice. For example, with a short inter-pregnancy interval, in some obstetrician may have practice that with short inter-pregnancy interval, in a patient there is increased risk of rupture, so I will direct procedure toward the emergency cesarean section. But in some obstetrician, they have a good approach toward the patient, and less chance when she give when the obstetrician give a trial to these patients with a short intra-pregnancy interval and her outcome are good. So that will not depend upon the patient, but these are the factors you keep in mind, and you have to be visual monitoring in these patients if you are giving VBAC option. Antenatal counseling. What are the overall aim of antenatal counseling? The antenatal counseling with the previous cesarean birth should be documented in notes. A final decision for mode of birth should be agreed upon by woman and member of the maternity team before expected planned date of delivery. When a date of emergency cesarean section where the rate of elective when the rate of emergency when the rate of cesarean section is being arranged, a plan from the event of labor starting before the scheduled date should be documented in notes. The routine use of VBAC checklist during antenatal counseling should be considered, as they would ensure the informed consent and shared decision making undergoing VBAC. A patient information notice should be provided with consultation. So these are the important factors and increased risk of VBAC when you have do antenatal counseling of the patient and make a checklist of all these things. So there is success rate of the success rate will be increases. The antenatal counseling process should be documented in the medical record where possible. Outcomes from women who give birth at term 37 to 42 weeks of gestation should be used for the purpose of antenatal counseling and used throughout this guide. Up to 10% of the women scheduled for cesarean section go into labor before 39 weeks. It is a good practice to discuss and document plan for delivery if labor start prior to scheduled time. And you have to tell the patient that if you are planning for if you are planned that the patient is going toward the cesarean section direct and she may labor start before schedule, that she should have to come immediately to the hospital. What are the risk and benefit of planned VBAC versus emergency cesarean section from 39 weeks of gestation? Women should be made aware that successful VBAC have fewer complications and therefore the chance of success or failure is an important consideration. Women should be aware that greatest risk of adverse outcome in a trial of VBAC resulting in emergency cesarean delivery. Women should be informed that planned VBAC is approximately 1 in 200.5% risk of rupture. This is one of your SBA. Sometimes this value is given and sometimes this, so you have to memorize both 1 in 200 or 0.5%. Women should be informed that absolute risk of birth-related perinatal death associated VBAC is low compared to the risk for nulli parlus women in labor. Women should be informed that cesarean section is associated with small increased risk of placenta previa accreta in future pregnancy or pelvic adhesion complicated by any abdominal pelvic surgery. Risk of perinatal death with emergency cesarean section extremely low, but there is small increased risk in neonatal respiratory morbidity when elective cesarean section is performed before 39 weeks. The risk of respiratory morbidity can be reduced with pre-op course of antenatal steroid. So if you are planning her with the cesarean section and before 39 weeks, so we will give a course of antenatal steroid. So these are the important benefits of planned VBAC versus emergency cesarean section. So sometimes the counseling came, so you have to tell the patient both and pros and cons of both the procedure. So these are the important table, and SBs came from this, especially the percentages. Plan VBAC success is 72 to 75%. If successful, short hospital stay and recovery, you have to tell the patient. Cesarean section from 39 weeks, planned known delivery date is in select patient. This may, however, change based on circumstances surrounding maternal and fetal well-being in antenatal period. 0.5% risk of rupture, and the risk of rupture is less than 0.02%. You have to tell the patient with the cesarean section long recovery. Reduce the risk of pelvic organ prolapse, urinary incontinence in comparison with the number of vaginal birth. With vaginal birth, the increased risk of pelvic organ prolapse and urinary incontinence. Option for sterilization if fertility is no longer desired. Evidence suggests that regret rate is higher than the failure rate from sterilization. So if the sterilization is to be performed at the same time as cesarean delivery, counseling and agreement should be given at least 2 weeks prior to the procedure. Increased risk of future vaginal birth and future pregnancy like to be required cesarean section because already one previous cesarean section done, if two done, so the future risk of further cesarean delivery placenta previa accreta adhesion. Anal sphincter injury in women with VBAC is 5% and birth wave strongest predictor of that. The rate of instrumental delivery increase up to 39 is one of the SPA that sphincter injury in women undergoing VBAC is 5%. So uterine rupture, previous uterine rupture percentage is 5% and risk of anal sphincter injury is 5%. Risk of maternal death planned VBAC is 4 per 100,000 and maternal death with cesarean section is 13 per 100,000. What about the infant outcome? Risk of transient respiratory morbidity is 2 to 3% and with cesarean section it is 4 to 5%, a bit higher risk. 6% if it delivery performed at 38 weeks instead of 39. So these are the percentages you have to remember. The risk is reduced by antenatal steroid. So if you are planning delivery before 38 weeks, you will give steroid. 0.1% risk of antepartum stillbirth beyond 39 weeks while awaiting for spontaneous. So, with the if you are planning for VBAC, so the risk of stillbirth after 39 weeks is 0.1%. 8 per 10,000 0.08 risk of HIE hypoxic ischemic encephalopathy, and with cesarean it is less than 0.01%. And 4 per 10,000 risk of delivery related perinatal death. This is compared to risk for nulliparous women in labor. So these are the few things you have to memorize. The table, this table is very important for MCQ's point of view. So what are the adverse outcome regarding, so the uterine rupture they have already discussed in detail in this, that how much is the, but this point is that with the rate of uterine rupture differ according to whether VBAC labor is spontaneous. Spontaneous is 0.5%, with induced that is 0.5 to 1.4, or augmented is 0.9 to 1.9. These percentages are also important for SBA. That if the patient go in spontaneous labor, the chance of rupture is 0.5, and if you are planning for induction, so the risk is a bit increased, 0.5 to 1.4, with augmentation 0.9 to 1.9. You have to memorize these percentages. And what about the hysterectomy? Successful VBAC increases risk of rupture 2.3 versus 0.1, hysterectomy 0.5 versus 0.1, transfusion is 3.2 versus 1.2, and endometritis 7.7 versus 1.2%. So these are the risk of hysterectomy and other morbidities. Acha, now this is also important for SBA point of view. This line that women should be informed that success rate of planned VBAC is 72 to 75%. So although excluding these women who required elective, these are the points for the success rate after VBAC is 72 to 75%. But the other SBA is that the patient is having previous vaginal delivery. What is the success rate? So the success rate is above more than 90%. Previous one, vaginal delivery 72 to 75, and previous vaginal birth, and now the patient is having chance of successful delivery is more than 90%. These are the patient with one or more previous vaginal birth should be informed that previous vaginal delivery, previous VBAC is the best successful for VBAC and is associated with success rate of 85 to 95%. So these percentage are important. Several pre-admission admission adverse model, women are at increased risk of unsuccessful VBAC and also increased risk of uterine rupture, including catastrophic rupture leading to perinatal death. Research is exploring that value of transvaginal and transabdominal ultrasound assessment of myometrial thickness to predict VBAC success and uterine rupture, although the prediction model out to be intuitively beneficial. Such models have not been routinely applied in the decision-making process, and their process role is yet to be established. 2013 meta-analysis have concluded that further prospective research is required. So, the role of transvaginal or transabdominal to check the assessment of myometrial thickness and predictor of VBAC success is a bit not yet confirmed, and research is going on this. So no need of to check the myometrial thickness. A VBAC score have been some author to predict the success of women attempting VBAC. The retrospective VBAC score eliminated 5 feature: admission, bishop, age, what is the previous cesarean indication, and BMI, and previous vaginal birth. So these are the important things you have to while doing examine the patient and counseling of the patient. So you have what is the admission bishop score, what is her age, what about her previous cesarean delivery indication, what are the indication, then what is the BMI of the patient, and whether she is having a previous vaginal birth or cesarean section. So the higher the VBAC score, the higher the success rate. The success rate of women with a VBAC score of more than 16 are greater than 85%, and those with a VBAC score of 10 have a success rate of 49%. So these you have to assess the score by these 5 features. What is our admission? Bishop, age, previous cesarean, and BMI. Induced labor, no previous vaginal delivery, BMI greater than 30, and previous cesarean for labor dystocia are associated with increased risk of unsuccessful VBAC. If these are the factors present, successful VBAC achieved in 40% of the cases. So these are very important, that whether it is spontaneous labor or induced labor, what about her previous delivery, BMI, and previous cesarean section. So, how the BMI will affect the vaginal bag? Greater maternal height, maternal age less than 40 years, BMI less than 30, gestation of less than 40 weeks, and infant birth weight is less than 4 are associated with increased risk of higher successful VBAC. So this is very important. You have to consider what about her age, what about her BMI, and what is her gestation. Now there is a important few percentages in this line. Successful VBAC is more like a woman with a previous cesarean section for fetal malpresentation. So with malpresentation, if the previous cesarean section with the malpresentation, so the success rate is 84%. And those with the labor dystocia, the success rate is 64%, and those with the fetal distress 73%. These are the percentages important for SBA point of view, that the patient is having a previous cesarean section with a for fetal malpresentation. So the success rate will be 84. Overall success rate is previous one with no previous delivery, that is 72 to 75%, and with previous delivery the success rate is 85 to 90%. But in MCQ came that the previous cesarean section for fetal malpresentation, so the success would be 84%. And if they say that the previous cesarean section is for labor dystocia, so the success would be 64, and for fetal distress you will have a 73%. So DDM, dystocia, distress, and malpresentation. So the dystocia will be 64, malpresent 64, and the distress is 73, and the malpresentation is 84. So 6, 7, 8, and 4, 3, 4. You have to memorize like this. Intrapartum, how will you manage the patient is in labor and with the previous cesarean section and came in labor? How will you manage this patient? So women should be advised that planned VBAC should be conducted in a suitably staffed and equipped delivery suite. So ideally, these patients with the previous one cesarean section should not be delivered in maternity care. You have to refer this patient to especially tertiary care hospital. Continuous intrapartum monitoring available for immediate delivery, and all the things are available in the hospital. Women with unplanned labor and history of previous cesarean section should have discussion with experienced obstetrician to determine feasibility of VBAC. So, for example, if you are a trainee and when the patient came with the previous one, you have to discuss with your SR or AP, because it is a shared decision. Epidural anesthesia is not a contraindication in planned VBAC, although increased requirement for pain relief in labor should awareness of the possibility of impending rupture. So, women should be advised to have continuous electronic fetal monitoring for the duration of planned VBAC, commencing at the onset of regular contraction. So, the one of the indication for continuous electronic fetal monitoring is previous one cesarean section. You will not do in every patient. We will not do continuous electronic fetal monitoring, but there are certain indication we will discuss in intrapartum care, that in which patient you will do continuous electronic intrafetal monitoring. So the one is your indication is previous one. So whenever the MCQ came as a previous one cesarean section, and they have to tell that what is the best option for the patient to prevent the patient from further rupture or cesarean section. So you will give a stepwise approach. So you will give a support one-to-one care, IV access with full blood count and a blood group, and safe continuous electronic fetal monitoring, regular monitoring of signs and symptoms, and regular no less than 4 early assessment of their cervicometric progress in labor. So these are the important when the patient in labor, you have to check. You will provide a continuous support, IV access with full blood count. You have to arrange, take a proper consent, keep fully prepared for cesarean section because anytime she may need cesarean section. And continuous electronic fetal monitoring is very important. Now, how will you check that the patient is having a uterine rupture or not? Because with the previous one, risk of uterine rupture, and how will you assess? So, the presence of any feature in the list below is suggestive of uterine rupture. Abnormal CTG is the most consistent finding in uterine rupture and is present in 66 to 77% of the event. SBA came from this that how will you assess that the patient is having uterine rupture? So, the best predictor is CTG with a percentage of 67, that CTG will get a good predictive value and identify the uterine rupture. However, half of the case with a combination of findings, abnormal CTG, abdominal pain, the diagnosis is made at emergency cesarean or postpartum laparotomy. Most uterine rupture, more than 90%, occur during labor, and the peak incidence being 4 to 5 centimeter cervical dilatation, with around 18% occurring second stage of labor and 8% being identified post delivery. So, more than 90% occur during labor, that is 4 to 5 centimeter of dilatation. 18% occur in second stage and 8% occur post vaginal delivery. So these are important. That 90% during labor, 18% second stage, and 8% still post delivery, 8% chances of risk of uterine rupture. The clinical features, abnormal CTG. In MCQ, you have to choose that the abnormal CTG. If then risk chances of uterine rupture. Severe abdominal pain, if persisting between contraction, acute onset scar tenderness, abdominal vaginal bleeding, hematuria, cessation of previous efficient uterine activity, maternal tachycardia, hypotension, fainting or shock, loss of station of presenting part, and change in abdominal contour and inability to peg fetal heart rate. The risk of uterine rupture in unscarred uterus is extremely rare, that is 2 per 1,000, 0.2%. And the risk of uterine rupture in plan V bag is 20 to 50% per 1,000, and in emergency cesarean is 2 per 10,000. So these are also important percentage. Early diagnosis of uterine scar dehiscence or rupture followed by expeditious laparotomy and neonatal are essential to reduce associated morbidity and mortality. So, scar dehiscence is, you have to be vigilant regarding the scar. It is important to note that scar dehiscence may be asymptomatic in up to 48% of the women. The classical triad of complete uterine rupture, pain, vaginal bleeding, and fetal heart rate abnormality may be present in 10% of the cases. And there is chance that pre-labor scar dehiscence may be there with previous one. Women should be, how should women with a previous cesarean birth should be advised in relation to induction and augmentation? Women should be informed that 2 to 3-fold increased risk of rupture and around 1.5 risk of cesarean delivery in induced or augmented compared with spontaneous VBAC. This is one of your SPA, that with the risk of 2 to 3-fold increase of uterine rupture with the induced or augmented labor and 1.5-fold risk of cesarean delivery. A senior obstetrician should discuss the woman, the decision to induce labor, the proposed method of induction, the decision to augment labor with oxytocin, the time interval for serial vaginal examination, and selected parameter. So whenever the patient wants induction of labor, you have to discuss all the parameters. Clinician should be aware that induction of labor using mechanical methods, amniotomy or Foley catheter associated with low risk of rupture compared with induction using prostaglandin. So if you are planning to go towards the induction of labor in previous one cesarean section, so the better option is amniotomy or Foley's catheter. Avoid prostaglandins because they are more chance of rupture with prostaglandin. So these are the important. So whenever these are MCQ, so whenever MCQ came as a previous one and about the induction of labor, so you have to choose Foley's catheter. Planning and conductive cesarean section. What element involved in pre-op, intra-op, and post-op care for cesarean section? Cesarean section should be conducted after 39 weeks of gestation. Antibiotics should be administered before the skin incision. All women cesarean section should reduce thromboprophylaxis if she is a candidate for thromboprophylaxis. Early recognition of placenta previa, adopting a multidisciplinary approach and informed consent in management of with previous placenta previa and previous cesarean section. How should come a woman in special circumstance care for? Clinicians should be aware that there is uncertainty about the safety and efficacy of planned VBAC in a pregnancy complicated by post-date twin gestation, fetal macrosomia, antepartum stillbirth, or age more than 40 years or more. A cautious approach is advised if VBAC is being considered in such circumstances. So, for example, the patient is post-date having a twin pregnancy, fetal macrosomia. So you have to be very vigilant in these patients and cautious approach if the VBAC is planned. Women who have preterm or considering have the option for birth after cesarean delivery should be informed that planned preterm VBAC has a similar success to planned term VBAC, but with a low risk of uterine rupture. So you have to proceed toward the normal vaginal delivery with the preterm and previous one cesarean section, as success rate for both is same. Now, what about the post date, the 41 weeks or the nice induction of labor? Recommend induction of labor from 41 weeks as reduce the perinatal mortality without increase in cesarean delivery. There are no adequate data whether approach is equality valid in women. The risk of stillbirth after 39 weeks is 1.5 and twofold higher in women with previous cesarean delivery compared with women without previous, that is 11 per thousand. So this percentage is also important, that the risk of stillbirth after 39 weeks in previous one cesarean section is 1.5 to twofold higher in women with previous cesarean delivery compared with women without previous cesarean section, that is 11 per 10,000. So, a reasonable approach for women with planned VBAC who have reviewed by senior obstetrician at 41 weeks. So, for example, if the patient is having previous one and at 41 weeks of gestation, if the spontaneous labor is not ensured, so how you will check that the likelihood of VBAC? For example, if you have favorable cervix, previous vaginal birth, absence of any obstetric or antenatal or fetal complication, then what you will do, her understanding of the increased maternal and perinatal skill, and if induction is chosen, her preference for membrane sweep, spontaneous VBAC, induced amniotomy or prostaglandin, or cesarean section for future reproductive preference. So in that case, schedule provisional cesarean section around 40 weeks plus 40 plus 10 weeks and converting to induction of labor depending on the clinical and cervical assessment at 40 plus 6 weeks. So you have to, if the patient is if you are planning for vaginal back after after birth, so in that case she is above more than 40, at least 40 plus 6 weeks. So in that case you will check the patient if she is having a no other complication. So you will do membrane sweep. So first option is you will be membrane sweep and you will wait for at least 1 week and you will check and if there is no contraindication you will wait for at least 41 weeks, but the risk of with the previous one cesarean section and proceeding after 41 weeks there is increased risk of stillbirth. So you have to individualize the patient. So and that with the twin gestation, similar success rate of VBAC in twin pregnancy, those in a single pregnancy. If both are cephalic, so better option for that is if previous one and twin pregnancy and both the babies are cephalic, so you can give a trial of vaginal delivery, but depend upon the obstetrician experiences. Successful fetal macrosomia, what will in this case? The birth weight of 4 kg or more associated with increased risk of uterine rupture, unsuccessful VBAC and shoulder dystocia, and third and fourth degree perineal restoration. For women with no previous vaginal delivery undergo VBAC labor when neonatal birth was 4 kg or higher, the VBAC success was repeated less than 50% and uterine rupture was 3.6%. So, the study analyzed that women with a previous cesarean delivery for dystocia, greater birth weight, and subsequent planned VBAC labor was associated with decreased likelihood of successful VBAC. However, third trimester ultrasound is a poor predictor of macrosomia and decision making regarding VBAC. So the better option for that is with the high weight, birth weight of more than 4 kg, because the risk of rupture is 3.6%. So better option is proceed toward the cesarean section. Antepartum stillbirth. Women with antepartum stillbirth and previous cesarean section undergo labor with a higher success rate of 87%. The care of these women should be in line with national guidelines because the proportion of case required induction or augmentation reported a rupture of 2.5%. So the patient was having a previous cesarean and having antepartum stillbirth, but and in labor. So in that case, success rate is 85%. If the patient is not in labor, so better option with the previous one and previous stillbirth, proceed toward this option of cesarean section, and this will be basically individual the obstetrician preferences. But when the patient is labor and having a previous stillbirth and a previous one, you have to give a short trial of labor and keep fully prepared for cesarean section. Maternal age of 40 years or more. Maternal age is an independent respector for stillbirth and unsuccessful VBAC. Consideration of delivery of women age 40 years or more, 39 to 40 weeks, to reduce the risk of adverse perinatal outcome. However, the likely adverse effect of previous cesarean delivery and raised maternal age on the risk of antenatal stillbirth. So, consideration should be given to the timing of the delivery in women aged 40 years or above who plan VBAC. So, you have to be very vigilant in these patients of a maternal age of 40 years or more, and because they have a maternal adverse outcome and a risk of increased risk of stillbirth. Preterm VBAC. Success rate of preterm and term pregnancies are similar, 72.8 and versus 73.3. So VBAC success for preterm is 72.8 and the term is 73.3. The risk of rupture is 34 per 10,000 versus 74 per 10,000 respectively. So at least this is 0.3 and 0.7%. So with preterm rupture is chance of rupture is 0.3%, and with term that is 0.7% or 0.5 to 0.7%, and dehiscence is 2.2 per 10,000. With success were significantly lower in preterm compared with term VBAC. So these percentages also a bit important in both preterm. So hope you find the lecture